So with the lateral, you want to make sure the hard palate is parallel to the floor, or the horizon is ideal. If it's a little up or a little down, it's okay, but you want it to be the same on post x-rays. You see all the time the hard palate will be like this on the pre-x-ray, and then it's like this on the post x-ray. Hey everyone, Dr. F.J. Schofield, West Bend, Wisconsin chiropractor. So I'm going to get some of these lines out of the way here. We'll just redraw them for you. So in the beginning, I recommend drawing as many lines as possible. Gives you the more information, the better. But here, so I'll start with what I do now, and then also what you need for upper cervical, if you're looking to do some of that, or do it occasionally on tough cases. First thing you need a lateral for with upper cervical is to see the S line, how superior or inferior the atlas is. Because then when you shoot the x-ray, and we'll go through this when you take the nasium, you want that x-ray to be coming right through there. That's going to give you your most accurate analysis. So either you tempt the central ray, or you shoot the central ray down and you tip their chin down and basically have them tuck their chin until this is level to the ray. But you need to know where that's at to know how they're either going to tuck their chin or how much angle you're going to put in the central ray. So that's the S line. You can take it a few different ways. Gonstead chiropractors will take this as well. A lot of chiropractors will do it. But you can either do, you can see we do the inferior aspect of the posterior arch right here, where it's, and then the posterior inferior aspect of the posterior arch back into here, where it's coming into the posterior tubercle. And then you got your lateral mass here with the transverse. And then you got anterior tubercle. So some people will shoot right through the center of the anterior tubercle and in the center of the anterior aspect of the posterior arch. You could do that. So basically be this line here with this line, which is pretty much the same. It's pretty much right through the center of the anterior tubercle. Doesn't really matter as long as you do it the same every time. That's really the same. It needs to be congruent. But it doesn't really matter. Then you need contact point. If you're going to do upper cervical work, you need to know exactly where this atlas transverse process is located compared to some aspect of the patient's anatomy. What do I mean by that? Well, some people's, so these BBs are put on the very inferior aspect of the ear. I used to do it where the ear touches the face. Now we just do it right on the inferior aspect of the ear. It doesn't really matter either, as long as you do it the same every time. So you see these BBs, they're not lined up, so there's a little bit of head tilt and a little bit of rotation, but not enough to retake the x-ray. And then here you see the EAM, the external auditory meatus. So the ear hole, the hole in the ear. So if you know where this is, it's easy to know, okay, the atlas transverse is right here, and it's almost 4 millimeters, or about 1/8 of an inch anterior to the EAM. All right, we know that. And then you could go from the middle, or you could just bisect the middle of these BBs, and you could say, all right, that would pretty much be almost where the atlas was. It would be probably 1/16 of an inch anterior to the where the BB should be if there was actually no rotation or head tilt. You could do that. And then it's also about 3/4 of an inch superior to the BBs if you bisected them. That would also work. Now you can also get that information from the nasium. So you could do it all on the lateral, or some lateral, some nasium. It's up to you. And I'll show you on future videos how to do it on the nasium. So, but how far anterior, posterior, you can't really do on the nasium. You don't have any perspective of that. So superior, inferior, you can do on the nasium. How high or low compared to the BB it is. So it's right at the EAM, or excuse me, it's about an anterior, 1/8 of an inch anterior to the EAM, and it's about 3/4 of an inch superior to the BBs, or to the most inferior aspect of the ear. So now we know exactly where that atlas is, because you don't want to be on C2 or up on the skull when you're trying to move the atlas, because nothing's going to move, and you're going to get frustrated, you're not getting results, and you're just not on the right anatomy. Everything else could be right. You could have the right, perfect x-rays, great analysis, you got the right vector, whatever it is, right adjustment, everything, but you're just not on the anatomy. And you could be changing things and doing things, and all you need to do is get on the atlas. And it's usually I would say about a little anterior of the EAM, or at EAM is very common. So if you just went at EAM and you went about a ½ inch high of the most inferior aspect of the ear, or you went pretty much just above the dead middle of the earlobe, right at EAM, you would get probably 60-70% of patients. Problem with that is, what about those other 30 or 40%? You know, they're hurting, they need help. And sometimes you can't believe, sometimes I've had people that were 1.5 inches high of the BBs. So you think it's at the earlobe and it's way above the earlobe. Okay. So that's why it's important to measure it. So that's all you essentially need to do upper cervical work. And the lateral is obviously great to show how long the patient has been out of alignment. Very easy to see wear and tear. And again, misalignments are global. It's a whole body misalignment, not segmental. And you can see this person has been out of alignment a very long time. We'll just zoom in here real quick. Boom, boom. You see all this. I mean, this area is essentially fused. This area is basically fused. This is close. I'd adjust. I would be willing to do like a C4, seated Gonstead, or diversified adjustment. I wouldn't do anything down here. C5 to C7, I would leave alone. You could do a little bit of activator or work on the soft tissues if you want. Obviously, C3, C2, C1 are fair game. Discs are look good there. So a lot of wear and tear. You want to show that because maybe they just started having neck pain. You could just tell them, hey, this has been silently degenerating, deteriorating for decades. So the trauma that started this, if this person's 40, it probably happened when they were a little child. If this person's, you know, in their 70s, maybe it happened when they were a teenager, 20s, 30s, who knows? But it's been there a very long time. So with the lateral, you want to make sure the hard palate is parallel to the floor, or the horizon is ideal. If it's a little up or a little down, it's okay, but you want it to be the same on post x-rays. You see all the time the hard palate will be like this on the pre-x-ray, and then it's like this on the post x-ray. Then of course it's going to look like there's more it's going to look like there's more curvature. This person, this curve isn't changing. You got to tell them there's way too much wear and tear. These joints are not going to be able to move. It's like if a hinge is just rusted apart, it's not going to turn. Okay. So the curve's not changing. The forehead posture, maybe. If you center the head and neck, there is enough healthy joint structure here. Maybe that head will come back over the body a little bit. It may not. So sometimes you just got to see. The forward head posture, you go here from the sella turcica, the anterior aspect, you get a straight line down, and then you can do it either at C4 right here, or C5 is what I did here. You can see it's almost 48 millimeters, would be 2 inches. So we got 1 3/4 inches anterior. All right, and they've shown now in MRIs the forward head posture can change the diameter of the vagus nerve. The vagus nerve goes a lot of places, and so essentially it's not as pinching of the nerve, but it's more a stretching of the nerve. All right, so forward head posture, very, very big deal. Now, if you're doing full spine, what I would come next is get on these like C2, do the inferior anterior and inferior posterior aspect of the bodies. So just boom, boom, draw it out. Boom, boom. So what Gonstead taught was you take it where it's converging. But back in those days, basically everyone had a cervical curve. If this person has a cervical kyphosis, nothing is going to be, so if the curve's going the wrong way, if it's going this way, nothing's going to be converging. So how do you decide what to adjust? What I would recommend in those cases is you take what's most diverging. So I still think it's fine to go off Gonstead's rule of thumb if there is curvature. So most diverging would be right in here, right? So C3, C4 is where I'd be looking. These are pretty diverging, and the disc spaces and everything is healthy enough for an adjustment. I wouldn't try to mobilize or crack anything C5 through C7. Okay. I've had people that have come from other docs and they've had this stuff done and it's been okay. Then I've also had people that went to other docs, had it done, and it was terrible. It really hurt them. So then you could also come here at the occiput and just get, and they always thought parallel to atlas, which that's pretty close to. So that's pretty good atlas occipital alignment laterally, sagittally. So I would come here, look really at C3, C4. for what I wanted to adjust, I would look at, and then correlate that with palpation, static and motion. What's not moving? That'd be one of my biggest signs. What's not moving? And then of course, what hurts? What's swollen? Then if you do instrumentation, where is the instrumentation showing you? And combine that. And then I also always like challenges. So push on an area and see if that causes the legs to contract or not. And then use all of that together to then decide where you want to adjust. But I'd look very hard here at C3, C4, and then always C1. Always look at C1. If they had any trauma in their life, C1 will be affected. And it's the king area. The brainstem sits right here. I'm a big atlas guy. So always look at and adjust C1. Always. I would start at C1 here, adjust that, then check everything else out and go from there. So that's how you do the lateral. If you have any questions, please leave them in the comments. If there's any other videos that you'd like to see that would help, let me know that in the comments as well. If you know someone this could help, please share it with them. If you want to be notified on our videos coming down the pipeline, subscribe for the newest information, and we'll hopefully help you take charge of your practice, take charge of your life, and take charge of your health. Have a great day.